any one of any disclosure about Wilkinson's? Thank you very much.
I have lots of disclosures.
Next speaker is Dr. Akash Shukla from Mumbai. Another important topic is HIV-HCV co-infection, please. Dr. Akash Shukla.
Thank you very much. I thank the organizers for inviting me and giving me this opportunity to share. I happen to share Bazare, and we manage these patients together. So we know that hepatitis C is the most common blood-borne infection all over the world, and we have a huge population, around 2% of the world, who is hepatitis C positive. In India, we estimate around 1% of the population to be hepatitis C positive. We need to know the genotypes still because we don't have Alpetacevir yet in India, and therefore, all over the world, genotype 1 is the most predominant genotype, whereas in India, the predominant genotype is genotype 3, and only 20 to 30% of patients are actually genotype 1 in India. If you look at overall, around 4.5 million persons are estimated to have the co-infection. This is much less in India, and we estimate probably around 50,000 people to be co-infected with the two viruses in India. Let's see what is the incidence of HCV infection in HIV-infected MSM. A long follow-up study, 1984 to 2011, and they found that the HCV incidence rate was almost 8.5 times higher amongst HIV-infected versus HIV-uninfected men. So HIV-infected was 4.22 per 1,000 person years, as compared to HIV-negative, which was 0.5 per 1,000 person years. IV drug abuse had a very high risk, so was sexual exposure, and delayed enrollment, that is in the 2000 and beyond, as compared to those who were enrolled in the 1980s and 90s. So this basically tells us that the percutaneous mode of transmission and HIV co-infection are associated with a higher risk of transmission of hepatitis C virus. We know that the mortality is going down because of HIV. At the same time, in USA, the HCV-related mortality is going up. The number of transplants required because of hepatitis C is going up. The watershed period was around 2005-06 in the USA, where we saw that the mortality equaled because of hepatitis C and HIV. In India, we are reaching probably now the stage where the mortality is equal because of hep C and HIV. Probably another 10 years and we'll have more mortality due to HCV than HIV. So when you have somebody who has HIV, what should we do? We should be screening everybody for hepatitis C antibody. There's an anti-HCV antibody in the blood. Those who are negative, they should be annually screened for HCV by anti-HCV antibodies. Those who are positive, we always do a HCV RNA to confirm the presence of active infection. And to plan the therapy, we need to do a genotyping and we need to stage the disease. By staging, we mean the stage of fibrosis. We can estimate this clinically if there are obvious signs of cirrhosis, like very low platelet counts, less than 1.5 lakhs, if the patient has obvious decompensation, if the patient has high bilirubin, low albumin, abnormal PTINR, abnormalities of liver synthetic function, it's a clear-cut case of advanced fibrosis or cirrhosis. Whereas for other patients, it may be a little difficult, where you can rely on non-invasive markers like fibrotest, fibrometer, or fibroscan, or MR elastography, depending on what is available at your local place. All patients who have tested for HCV positive and have HIV should also be tested for hepatitis B, and vaccination for hepatitis B must be given to all who are negative for hepatitis B. These patients should also be on HCC surveillance because the co-infection is associated with almost 8 times higher risk of HCC as compared to HCV monoinfection. So when we think of management of patients with HCV HIV co-infection, what are the guiding principles that we have? So the benefits of ART outweigh the concerns regarding the drug-induced liver injury. So ART should be initiated regardless of CD4 count, including patients with hepatitis C-related cirrhosis. Although ART should be initiated in the co-infected patients regardless of CD4 count, in ART-naive patients with more than 500 CD4 count, some may choose to defer ART until HCV treatment is completed. This has definitely become easier now because of the shorter durations of therapy, with just 3 months of therapy for most patients for hepatitis C. For those who have a CD4 count of less than 200, ART is of course initiated expeditiously, and we may decide to defer the hepatitis C therapy until the patient is stable. The initial ARV regimens are the same as those for patients without HCV infection, and concurrent treatment of HIV-HCV is feasible, but may be complicated by pill burden, drug toxicities, and drug interactions. And I'll be talking about some of these drug interactions in the next few slides. So the guiding principle is they should be treated or retreated the same as people without HIV infection after recognizing and managing interactions with antiretroviral drugs. So we had sofosbuvir, which was approved in April 2014 with us. This is how the different DAs work, and sofosbuvir in India forms the backbone of all therapeutic regimens involving hepatitis C therapy. This is something which is extremely important for us. It is a potent drug which is pan-genotypic. It has a high barrier to resistance. It is basically a 5A inhibitor, so it inhibits the polymerase formation. It's effective against the drugs. It is effective against the virus which are resistant to the NS5A variants, drugs. So all the presence of RAVs to NS5A drugs is not a contraindication to use of sofosbuvir. The advantage is it doesn't have any interaction with food. It is renally cleared, doesn't have a CYP450 metabolism, and has few drug interactions. But the drug interactions which are there, we must be aware of to prevent complications. The beauty of the drug is it is a prodrug, it is inert, unless it reaches inside the hepatocytes. Once it is inside the hepatocytes, inside the liver cells, it becomes activated to GS461203, which is then within the hepatocyte again converted to the inactive circulating metabolite, which is GS331007. So the circulating form in the blood is actually the inert form. And that is why this drug is very well tolerated. Renal clearance is the major elimination pathway. However, patients with moderate renal impairment, anybody with a GFR of more than 30, can tolerate normal doses of the drug. No dose adjustment is required for patients with any degree of hepatic impairment. No impact of HCV patient characteristics such BMI, sex, or presence of cirrhosis on exposure or side effects have been noticed, and there is no effect on the QTC interval. It is to be always used with other drugs. It should never be used as a monotherapy. It has been indicated for all genotypes of hepatitis C. It has also been approved for use in patients with hepatocellular carcinoma awaiting liver transplantation because of hepatitis C, and in HCV HIV-1 co-infection. When we use it along with the antiretroviral drugs, do the pharmacokinetics change? As you can see here, across the drugs, whether on the left side, you can look at the 4 drugs which are commonly used, and on the right side, you can look at the 7 drugs which are commonly used, and the therapeutic levels are very much constant across the different drugs, and they do not go out of the therapeutic window that we have. So these data support potential use of 400 milligrams of sofosbuvir with most commonly used antiretroviral regimens in patients of co-infection. The co-administration with Tiprenavir is not recommended since soft exposures are expected to be decreased due to the PGP inducing effect. This was the pivotal study of genotype 1 to 4, where they gave 12 to 24 weeks of therapy. Most of the commonly used drugs were included, and we found more than 80% SVR rates, which are cure rates. For genotype 3, the cure rates with 24 weeks were more than 90%. This was with just SOF and ribavirin. However, it did not do well in patients who had cirrhosis, where the rates came down to around 60%. Similar thing was seen in genotype 3, where in patients who were previously treated and not responded, the success of the therapy in patients with cirrhosis came down to 80%. So sofosbuvir was good for patients who were naive and did not have cirrhosis for 12-week regimen with ribavirin alone. When they looked at role of SOF plus ribavirin with or without pegylated interferon in co-infected patients, the results were comparable in all the genotypes and across the cirrhosis status. More importantly, it was very well tolerated. The rate of grade 3 to 4 adverse events was less than 10%. Then we had the combination of SOF ledipasvir, which is a once daily oral 90 milligram tablet of ledipasvir combined with 400 milligrams of sofosbuvir, once a day, fixed dose combination tablet, which can be administered irrespective of the food, very good pharmacodynamic and pharmacokinetic profile, 8 to 12 weeks of therapy for most indications for genotype 1. In co-infected patients, in this study, majority of the patients actually were cured, more than 95% cure rate with just 12 weeks of once a day, one tablet. This was the IN4 study. Again, if you look at patients with high viral loads, 7 logs HCV RNA, the usually used HIV regimens, and you see again more than 95% of patients, irrespective of their previous treatment status, achieved cure rate. Irrespective of cirrhosis, the cure rates were more than 95%. Irrespective of their CD4 count, the cure rates were more than 95%. So across the different profiles, patients were achieving more than 95% cure rates with SOF ledipasvir in genotype 1. Same thing, but more importantly, the safety. Very well tolerated. Treatment discontinuation due to adverse events was 0. Death was 1, which was less than 1%. The most common adverse events that we also face in clinical practice are headache and feeling of tiredness. This is especially common in people who have previously headaches and history of migraine. There was no compromise of renal function, even in patients who were put on tenofovir therapy. So in co-infected patients, now we have evolved to such a stage where we can achieve cure rates of almost 90%. Of course, there's a problem with the concomitant use of tenofovir because of the involvement of the pharmacokinetics, because of want of time. I can't go into the details. But what we have to realize is, in patients who are on ritonavir boosted PIs, use of SOF-LEDI does increase the levels of tenofovir, and this can give rise to toxicity, and therefore these patients should be very closely monitored. So to summarize the drug interaction profile of SOF-LEDI, no clinically significant drug interactions with most of the ART drugs, but it increases tenofovir exposure, especially in patients who are on LEDI-SOF and on ritonavir boosted regimens, and concomitant administration of SOF-LEDI is not recommended with tiprenavir or elbitiregravir, cobicistat, FTC tenofovir combination. So they say that the recommendation is ARV drug switches, when needed, should be done in collaboration with HIV practitioner, and for HIV, ARV, HCV, DA combinations not addressed below, expert consultation is recommended. So what is the recommendation? Because ledapursvir increases tenofovir levels, concomitant use mandates consideration of creat clearance and should be avoided in those with creat clearance less than 60 ml per minute. So again, declotazevir is available for genotype 3, similar dosage regimen, once a day for around 3 months, excellent results with 12 weeks, more than 95% cure rates across genotypes in patients with HIV co-infection. Again, we have to be wary of the side effects and the drug interactions. Declotazevir is very well tolerated, but it has very similar drug interactions to sofosbuvir, and it should be used, its dose has to be adjusted in patients who have got either enzyme-inducing activities or enzyme reduction activities. So to summarize, HCV therapy is safe and effective in patients who have co-infection with HIV with directly acting antiviral agents. Soft-LEDI is the treatment of choice for genotype 1, and soft DACLA is the treatment of choice for genotype 3. ART treatment interruption to allow HCV therapy is not recommended. Monitoring for tenofovir side effects is warranted when we use these drugs. Soft-LEDI should not be used with cobicistat and elvitegravir, pending further data. And soft or ledapursvir sofosbuvir should not be used with tiprenavir. Thank you very much.
Thank you. Thank you, Dr. Shukla.